Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And you know, we did a show a while back, just prior to last year's, shall we say, Breast Health Month. And there's been so many questions that have come our way, and so many things have emanated out of health awareness and new methods. So I decided, let's bring back some experts. And here we have two experts. Sitting in front of me is Dr. Kathy Schilling. Mm-hmm. Welcome, Kathy.
Thank you.
And she's the medical director of the Lin Women's Health and Wellness Institute at Boca Regional Hospital, mm-hmm. which is a neighbor of ours up the way. And we know very, very well. We do a lot of training in your hospital, some of our health students, professionals. And Dr. Cheryl Moss-Mellman, who is a director of clinical breast services. Welcome.
Thank you. Nice
Good to have you here.
Thank you.
Okay, Dr. Schilling, tell me about the Institute.
Well, the Institute is generously donated by Lynn. In 2010, she committed $10 million for us to move from a very old building into a brand new building. We had been in our original building for 25 years and started the Center for Breast Care there. We had the opportunity to move into a 46,000 square foot building after continued donation from the community. And we built on our breast care practice, mammography predominantly. We were seeing thousands of women every single year, and we decided that instead of just making a bigger breast center, it'd be great for us to offer other services, clinical services that women need. So we have Dr. Moss-Mellman there with us. We have internal medicine, urogynecology. Our breast surgeons are there. We do dermatology, and just one place where women can go and have a lot of the services that they need as they, age. But the main fundamental part of the foundation of the center is the breast center. And we are seeing over 60,000 visits a year for mammography services. So it's just a great, wonderful center, thanks to Lynn.
Good. Dr. Moss-Mellman, tell me about clinical breast services.
Well, it's nice for women who come to the center. They're not just coming for their imaging, but they get so much more out of their visit. One of the things that we really promote and feel very strongly about is that women know what is their individual risk of developing breast cancer. Almost everyone knows someone who had breast cancer, or they have a cousin or an aunt who had breast cancer. What is their risk of developing breast cancer? And there's a lot of women who are out there and really don't have a good idea of their risk. And for women who are at higher risk, they can be offered additional imaging services. So we do have advanced imaging surveillance, but what we need to do first is identify women, who are at increased risk. And so we do encourage women to have a breast cancer risk assessment so we can define their risk and personalize how they should be managed and imaged. So that's a big part of the service. I also see women who have any clinical breast concern. Maybe they think they feel a lump, maybe they're having breast pain or nipple discharge. They can come to the center and not just be imaged, but also be evaluated by a clinician. And they really have a very high level of coordinated care.
I would assume that with the comprehensive services of Boca Regional Hospital, Boca Raton Regional Hospital, that there must be a lot of referrals from OB-GYN individuals, the primary care physicians, et cetera. Is that true?
Well, medicine is most doctors who are in private practice, they're very busy. So for your primary care physician, they have to worry about managing diabetes, high blood pressure, heart disease. So it's nice that when women come to our center, my focus on them is just their breast health. And so they benefit tremendously from that. And a lot of women think, I'm just going to come get my annual mammogram, be told it's normal, and leave. But they really need a breast examination as well. Things are picked up on clinical breast exam. And when you combine a clinical breast exam with imaging, you're increasing the overall value of your screening. And it also provides women the opportunity to discuss, how can I decrease my risk of developing breast cancer? What things in my lifestyle can I modify? Am I a candidate for medical intervention to decrease my risk of developing breast cancer? So those are things that your average physician in practice, they don't have the time to devote to that discussion, and it's such a worthwhile discussion.
What is a natural order to the people out here? How often should they have a mammogram?
So we believe in early detection. Since we started screening back in the 80s, screening programs across the United States, we found that through routine screening on an annual basis, beginning at age 40, we're able to cut the mortality or the death rate from breast cancer by up to 35%. And we believe that that has occurred because we're finding things when they're early, when they're small and easily treated. And patients have more options for treatment when we find things that are small. With some of the new guidelines, patients are recommended to start beginning at age 50 and then only screen every other year, so every 2 years, and then stop at age 74. Well, we don't believe in those guidelines. The American College of Radiology, the Society of Breast Imaging, the American College of Surgeons believes that we should start at age 40 and image every single year with no upper limit, but stop when your health says that, perhaps I wouldn't want to act on something if it was found, but we don't give an upper age limit to our patients, but we believe early detection is really, really important. But one thing I wanted to mention to you is that mammography is not equally as effective in every single patient. Patients who have what is known as high breast density, it is less effective. So we can actually miss up to 50% of breast cancers in patients who have high breast density. And the reason for that is on the mammogram, the glandular tissue from which cancers arise is white, but cancers are also white, and so we have a masking phenomenon. We can't see things. It's like looking for a snowball in a snowstorm. We can't see it. So those patients, we let them know what their breast density is when they're at the center, and we recommend that they have supplemental screening, and ultrasound is the imaging tool that we use most commonly to find those cancers. And many studies have been found that when we supplement patients who have high breast density mammography and do ultrasound as well, that we're able to significantly increase the number of cancers that we're finding, and we find them when they're very small and very treatable.
I'm glad you brought that up, because just to let you know that here at Nova Southeastern we have a sonographic program, but it's a master's in sonography, and the foci are subspecialties, and one of them happens to be just what you just said. Yeah. So I'm glad you brought it up, because it's very important. Most people don't recognize the fact that a mammography is not a mammography that is always of 100% value.
Exactly.
You need the other service as well.
Exactly.
Dr. Moss-Mellman, tell me now, with all of the advancements of what I was going to ask you really was answered by Dr. Schilling. So I got the 1 year issue out of the way. But with all of the advancements today in genetic and genome involvement, not only in, I guess you could say, screening, but also in treating. Give us some insight.
So the first thing that you mentioned was a genetic predisposition.
Yes.
It's certainly important to identify women who have a genetic predisposition. There's certain features that will suggest that. Usually multiple cases of breast cancer within a family. We also look to see how old were the individuals when they were diagnosed. In particular, if the family members were diagnosed before the age of 50, there's going to be a higher likelihood for a genetic predisposition. There's other features we look for. Ashkenazic Jewish ancestry, particularly here in South Florida. We know that those women have a much higher frequency of harboring a BRCA mutation, which is the genes that account for the majority of hereditary breast cancer. So certainly when I do a breast cancer risk assessment, I want to identify women that I think may have a genetic predisposition. But I think it's very important to add that a lot of women think, oh, I don't have a family history of cancer, and therefore I'm not at risk. And the truth is that the majority of new cases that we diagnose of breast cancer are in women who do not have a significant family history of breast cancer. In fact, that counts for about 75% of all breast cancer cases. And that's really why we emphasize the importance of an individualized breast cancer risk assessment, because we know that there are many other factors that play a role in the development of breast cancer, whether it's reproductive factors, whether it's a history of previous breast biopsies, whether it's age in itself is the biggest risk factor in the development of breast cancer. And as Dr. Schilling mentioned, breast density, we talked about the importance that women need supplemental screening, but we should also add that breast density is also one of the important risk factors that play a role in the development of breast cancer. So not only does it interfere perhaps with a woman's screening, but it also is a risk factor that plays a role in the development of breast cancer.
You know, it's an interesting thing. We were having a conversation a few shows back relative to people with family histories. Well, we're still, even here we are in 2017, but you know, if you go back just the generations, parents, grandparents, but many of us have never seen great-grandparents. Right. I know I haven't, that's for sure. In fact, I have never seen two of my grandparents in my life. But when you think of it, I'm a big fan of finding your roots on public television, and I always think of how they gain access to knowledge and records, but it really gives family history, if you think of it. And you know, when we talk about family history, we're only talking about, you know, almost casual conversations that you hear from, for example, a mom or a grandmom.
Right.
You don't really get to know very much about their medical history.
Well, I think that for older generations, it was more hush-hush. So if someone had a cancer diagnosis, perhaps they didn't talk about it. And then you also see situations these days in which certain family members aren't in communication with other family members. And you know, if there is knowledge, or if there is a family member who knows that there is a genetic predisposition, that's knowledge that needs to be shared with all the immediate family members and first cousins, etc.
I don't really know how far back you can gain your knowledge from family predisposition. That's why I was interested in some of these genetic screenings and all of the items relative to that.
Well, with, let's say, for example, hereditary breast cancer, in which the defect is most frequently found in the BRCA mutations, those genes are what we refer to as autosomal dominant. So generally speaking, if someone is a carrier of such mutation, it's going to manifest itself.
Right.
So you don't have to necessarily have the knowledge of great-grandparents. You could probably look within, you know, 2 generations to actually see it manifest itself.
Right. Dr. Schilling, the comprehensive nature of what the Lin Women's Health and Wellness Institute is all about, but specifically the reason I wanted to focus in on breast services is because here we are again, and I give great salute to Ordination and their pink plate awareness project. Certainly we love other people too, particularly here with the Case family. Rick and Rita Case are very active. You see the baseball teams and football teams and everybody wearing pink, and they change and everything. Does it bring awareness to the general public that you serve?
Yeah, I think it does. I think it at least makes people think about it, particularly in the month of October, Breast Cancer Awareness Month. We actually lit our building pink for the whole month of October to bring that awareness. Everyone who drives by in the evening, you know, gets to think about, am I doing what I need to do, or is my mother or my sister doing what they need to do about, you know, detecting breast cancer. Our focus at the center is really to improve the experience. We know that only about 2/3 of women who qualify for mammography actually come in and have it on a regular basis. So if the patient doesn't come in, that's a screening failure for us. We lost the opportunity to detect cancer. So we've really focused on, for the last 2.5 years, we've been in this building on the experience and making it very comfortable for women to come in and have their screening done. And we actually are a national show site for GE Women's Healthcare, and we have all the latest and greatest equipment that GE has for detecting breast cancer. And for mammography, it's really a unique experience at our center that no one else can offer our patients. We have these big, giant, high-definition TV monitors that display beautiful environmental scenes, as a waterfall or a garden or a beach scene. And these are around the mammography unit. So the patient, when they come in, they're distracted. They don't really see the unit. They're looking at the beautiful imagery. We have the sounds from those different environments that are also being played during the mammographic experience, and we have a very fresh scent that's infused into the room. So patient is distracted when they come in. We also have the next generation mammography unit, which is causes significantly less discomfort to patients. It's beautiful, it's tall and thin and has curves. Its detector is very thin, so it doesn't cause that discomfort that most patients in typical mammography units experience. And we call it, her name is Pristina, we call it a she. Her name is Pristina, that's her name, and she has a face, and she's we don't want to call it mammography anymore, it's a different experience. But the other thing we're going to be working with just beginning this week is that we are going to have patient-assisted compression. So what patients fear the most is the compression during the mammographic exam. The patient now will have a remote control device. She'll be in control and be able to deliver the amount of compression that she feels comfortable with. So she's in charge now. It's not somebody else applying that. So it's all this goes into our commitment to making that experience exceptional for the patient with the hopes that compliance will improve.
Dr. Moss-Mellman, what is the relationship between your clinical breast services and the treatment of the patient who has a cancer, shall I say, detected? What's the nature of your services?
Well, we have a wonderful comprehensive program, I'm happy to say. So women who have biopsies, I will often see them after their biopsy to give them their pathology results. And I'm happy to be able to say that no one leaves after getting a pathology result wondering, what's my next step? No one gets into their car. Everything is coordinated for that woman while they're during that visit. So in addition to discussing pathology results and going over and laying the foundation that's important to them, often after a diagnosis, we'll want to get more advanced form of imaging. Usually newly diagnosed patients will get a breast MRI, and that's to help us define the full extent of the disease. So that'll be coordinated for them. Our breast surgeons, our dedicated breast surgeons, are in the same facility, so we'll make sure that their consultation with the surgeon is scheduled before they leave. And then we have what we call multi-modality clinic, and that's right across the street from us at the Lin Institute. And I have the ability to tell my patients that they'll go to multi-modality clinic really within days, literally days of their diagnosis, have the opportunity to be seen by a medical oncologist, a radiation oncologist, a second medical oncologist whose specialty is genetics, and also be seen by a nurse navigator, a social worker, to truly learn, what is their situation, and to ensure coordination of their care. And then what happens after they go to multimodality, literally the very next morning, all the doctors meet together. So you'll have the radiologist going over their imaging, the pathologist is there, the surgeons, the entire multimodality team, myself, plastics, reconstructive surgeons, and together at the same table, we review all their information and truly come up with a plan that is the best treatment approach for them. And I have the ability to tell my patients that as they go through that process, it's going to give them tremendous peace of mind because they will sense how well coordinated their care is, and they'll sense the highly competent team of specialists that's involved in their care. It's truly a remarkable thing to offer women in our community.
Well, the reason I ask is because there's been such tremendous advancement. Even the utilization of new equipment from General Electric gives you new knowledge. I'm sure in your coordination of services with the surgeons and with the oncologists gives you new knowledge.
Well, we also have the ability to look at different features of a woman's cancer to help us understand how it's going to behave in any one individual. So breast cancer is not one disease. So we have what we call a prognostic panel, which includes looking to see does a woman's tumor have receptors for estrogen and progesterone. We look to see the grade of a woman's tumor. We look to see other features that help to define the biologic nature of the disease. And so truly that enables us to understand how breast cancer is going to behave in any one individual, and then how to target our treatment to that one particular individual. So I tell my patients all the time, we have the knowledge now. And so don't necessarily think of what happened to your mother, 20 years ago, or your neighbor. This experience might be a very different experience, and it's very important to emphasize that.
We're down to the last 4 minutes of the show, but we've been talking very good. But I want to touch on one thing because we hear a lot of questions, and I hope we can dispel the feature of, it's almost horror, which we get these questions about full breast mastectomy, full mastectomies, et cetera, et cetera, et cetera. Things have changed so dramatically, surgically and treatment-wise. True, Dr. Schilling?
Absolutely. Yeah, absolutely. I think there has been a criticism that, perhaps false positive imaging studies drive women to decide to have bilateral mastectomies where they have a very tiny tumor. But it's a very personal decision that women come to. Some of them would never think of doing anything like that, and others, it's the first thing that they say that they would do. But I think that surgically, the plastic surgery now is so excellent that it's not an unreasonable thing for some women, but it's very, very personal, and some women need more information to come to that decision. Others need less. But it's a very personal decision. But the surgery now is so awesome. They do oncoplastic surgery now so that the surgery is not as deforming as it used to be. But there's many options. And when we have a comprehensive team that we have, the multi-modality team, everyone is keeping up with the latest and greatest for their specialty. And that offers us, the opportunity to offer the best care to all of our patients.
Dr. Moss-Mellman, we got 1 minute for you.
It's a very individualized approach, and like Dr. Schilling was alluding to, women will feel differently. Some women want to be more aggressive, other women want to be less aggressive, and I think a lot of what it comes down to is what gives that woman peace of mind at night. How will she sleep better at night? And it's different for each individual. Mm-hmm. And so that's one of the benefits also of having that comprehensive team approach, is that they will get input from each of the different specialists, and they can digest that knowledge to really help them make a more informed decision. And we look at each woman as an individual because we know each woman has different set of needs.
Well, I've always said, and I've repeated this, this is our 17th plus year here, but I've always said that the greatest problem we have in society generally is not ignorance, it's non-knowledge. Mm-hmm. And once you have knowledge, mm-hmm. you can make so many good decisions. Mm-hmm. And I think that both of you have said the same thing. We did a show about, maybe 3-4 months ago about breast reconstruction, and it was really a fascinating show, mm-hmm. and it was very valuable to the patients or the potential patients that were viewing us, and as well as their family members. So I think it's very, to me, the intent of having these shows and having people like you, Dr. Moss-Mellman, and you, Dr. Schilling, is to mitigate the anxieties and provide information and provide knowledge mm-hmm. from these people out here, because that's what they want. Mm-hmm. They want knowledge. So I want to thank both of you for being here. I know of the Lynn Women's Health and Wellness Institute, and I know of the dramatic intent of of not only your institute, but now you have another institute there as well, a neurologic institute, which
Yes.
is employed. I use the word employed, but that's what it is. Physicians of great renown from around the United States, and I really think that it will bring some greater appreciation to the Boca Raton Regional Hospital. So I wish you both well. I thank you both for being here. Thank you again, Dr. Kathy Schilling, and thank you again, Dr. Cheryl Moss-Mellman.
Thank you.
Folks, if you have any questions, you have any comments, there's an email address and a telephone number right here. Just give us a call. We'll try to send the information on. If we can't get you an answer from us, we'll send it on to these folks. So take good care of yourself. This show is called Dateline Health. We come to you from Nova Southeastern University. Until next time, see you.